Jawan. She is from UT Southwestern Medical Center, and she will be our facilitator for today. So, Ankh, I will hand it over to you.
Sure. Thank you, Maura. So welcome, everyone. I'm really delighted you decided to join us for this webinar. This is, I think, a really important and compelling topic. I wanted to briefly introduce myself and kind of explain a little bit why I'm here and set the stage a bit for the webinar today, and then I'll introduce the speakers one at a time. So briefly, I'm an infectious diseases doctor. I focus mostly on HIV. I also do research. I work at a large safety net hospital here in Dallas and also at our county jail. And the reason I got into this field, particularly working in the justice system, was after I finished my fellowship I had in training in infectious diseases and HIV. I had the opportunity to work at Brown in Providence, Rhode Island, on a research fellowship. And they had asked me to start working in the prison, specifically on the women's side. And I really had never been to a jail or a prison before. I really did not know what to expect. I'll be honest, I was a little bit intimidated. And I was about 6 months pregnant at the time. So that added to sort of some of the just nervousness about going. And so I just started to see patients there with the idea that I would see patients and kind of determine some of the issues that I was seeing and think about what kind of research would I like to do in that setting. And so, in many ways, it was not that different from seeing patients in other settings. And I had certainly seen patients with substance use disorders before, or mental health issues, and HIV, hepatitis C, these types of things that were really overrepresented in this prison. But there was something, I did find myself just being even more curious about what the stories were behind the patients and how did they end up in this situation? And I remember really clearly a young woman who I saw very early on, and she was in her early 20s. She was really young, but she looked younger. Really, really beautiful woman, Latina woman who I was talking to, and we were managing her HIV and her hepatitis C, and she had a history of heroin use. And I kind of, I just kind of asked her about her story and what had happened. And what she told me was that, her home life was very difficult growing up. There was no dad around. And she, as a teenager, latched onto this boyfriend who really was sort of like a father figure to her and quote unquote took care of her. Unfortunately, a lot of that involved getting involved in drugs, and she became addicted to heroin pretty quickly. And then at 16 was pregnant. And when she was diagnosed with her pregnancy, she was also diagnosed with HIV and hepatitis C at the same time. And since that time has sort of been in and out of trouble and currently was in the prison. But actually, and so she in many ways embodies a lot of the issues I'm talking about with addiction. And she also had some mental health issues and certainly some medical issues. And I just felt sitting there myself, as I was quite a bit older than her, but was pregnant and had such a different life experience. And here she was very motivated to take better care of herself, to get back to taking care of her child. And I really felt, to me was really why I went into medicine, was to help people, and felt very compelled to help this young woman and other patients I met in that setting. I really, really wanted her to be successful. So to me, it just highlighted one of those moments which really points out some of the inequities, not just in healthcare, but in our society, particularly when we think about social determinants of health. And to me, was a real reminder of my mission, both in terms of medical care and research. And so I just wanted to share that story to set the stage for these talks. I think you're going to hear a lot about some of the issues I mentioned today from two really wonderful speakers and experts in the field. We're going to start with Dr. Meyer. So let me introduce her. So Dr. Jamie Meyer. She is an associate professor of medicine and public health at Yale. She's the associate program director for research of the Infectious Diseases Fellowship Training Program. She's also a practicing physician, board certified in internal medicine, infectious diseases, and addiction medicine. Her NIH-funded clinical research lab focuses on HIV prevention and treatment for women, addressing social and structural determinants of health, and her clinical work and research are motivated by her experience working as an HIV care provider at the only women's prison in Connecticut. So as you can tell, she and I share a lot of interests. So I will turn it over to Dr. Meyer.
Thank you so much, Anka. And it's so great to be here with you all. And thank you so much for the invitation to talk. I'm going to share my screen. Can you all see that okay? Okay.
Yes.
Okay. So I'm going to, in the next 15 or 20 minutes or so, basically give you a whirlwind, overview of what is the criminal legal system and why should I care? It is very clear, as you just heard, that those of us who are speaking today really care very deeply about these issues, but want to try to convey to you why it's important to the work that you do as well. Here are my disclosures, and I have no conflicts of interest to declare. But I do have a little bit of disclosure as well that that I'm very, as Anka mentioned in my bio, I'm very highly motivated. My work is motivated. My sort of professional passions are really motivated by the experience I had working here at York Correctional Institution for Women, which is the only correctional facility for women in the state of Connecticut. So it's a combination jail and prison. Houses up to 1,600 women at any time. And I spent almost 7 years there being the HIV care provider. And my work is really motivated by the women that I met there, the patients I took care of, and many of whom I continue to take care of now that they're home in the community. And I say this because no matter where I go and who I talk to, someone inevitably asks the question that is kind of flavor of what's a nice girl like you doing in a place like this. And so I just want to say that my work is really motivated by my clinical experience here. So today I am going to try to introduce to you the landscape of the U.S. criminal legal system with the full disclaimer that I am not a lawyer and I do not have a JD or anything, but I do have a sense of the landscape, and I'm going to try to bust some key myths for you about the criminal legal system that might be relevant to your interactions with clinical trial participants or patients or people in the community. I'll try to describe some key considerations for women and for the treatment of substance use disorders, and then briefly, real quickly, just the consideration for involvement in research, which often comes up, especially if we're talking about clinical trials. Okay, so sort of goes without saying that we are in the midst of an epidemic of mass incarceration, a very long-standing epidemic, where the U.S. incarcerates more of its citizens than any other developed nation worldwide. And 1 in 37 U.S. adults are currently behind bars or on probation or parole. Now, it certainly disproportionately impacts young Black men, especially in urban centers, and therefore compounds other health disparities. You heard a little hint of that just earlier about social and structural determinants of health, but certainly incarceration is a component of structural racism. Not everyone in this system are young Black men, however, as we'll talk about some of the implications of that. And before I go any further, I want to make sure that we use the right terminology for things and to use both accurate and non-stigmatizing language when we talk about the criminal justice system. And that's important, not just because like words matter, because they do, but also because words matter to people. We want to make sure we're using, sort of technically correct terms to talk about things and sort of not stigmatize people further for having criminal justice involvement. So first of all, jails are facilities where people are incarcerated while they're awaiting sentencing. So they're sort of pre-adjudication, they're waiting for their court date often, or they're sentenced to generally short terms, like less than a year. And depending on where you live, jails might be under the jurisdiction of the county sheriff. They might be under the jurisdiction of someone else in the county. In a state like Connecticut, they are under the jurisdiction of the state, or there are federal jails. And So each of these, there's a little bit different depending on where you are. And people often use the terms jails and prisons interchangeably, but they're very different beasts. Prisons are facilities where people are incarcerated following sentencing, or they're sentenced to longer terms. So this is sort of a more stable population. People are often grouped together based on the severity of their supposed crime or the duration of their sentence, and they're often housed in certain places based on their medical needs as well. And prisons can be under the jurisdiction of a state, like the Departments of Corrections, or federal, like the Bureau of Prisons. So jails and prisons are different. Probation, however, is a system of community supervision for people who are sentenced to it. And they're often sentenced to probation as an alternative to incarceration, or what's called jail diversion. Probation is under the jurisdiction of the state sometimes, or federal systems, but this is community supervision. And this is different from parole. So parole is, please don't mind my children coming in. Parole is a system of community supervision for people who've already completed a period of incarceration. So often they'll be sentenced to some sort of duration of imprisonment, and then on the tail end, sort of a period of parole and supervision. And they have to meet certain conditions of that parole. And if they violate any of those conditions, they can be reincarcerated. So parole can also be under the jurisdiction of the state or federal, but they're different. It's different than probation. Now, we want to try to use person-first language. So we are going to talk about people in prison or jail, a person who's incarcerated, a person on probation or parole. I am not a criminologist. I don't know if any of you are, but we are, clinicians, we are public health professionals, we are sort of community oriented. I never talk about my patients as inmates, criminals, felons, or offenders. That is criminology type language that sort of has no place in public health. Okay, so this whole system, jails, prisons, probation, parole, all in all, is a system of what's called corrections. You can debate whether or not there's anything correctional about it, but that's the system of corrections, and combined with law enforcement and courts, that really makes up the criminal justice or criminal legal system. Okay, so there's this, I'm going to go through some myths or misperceptions. So there's this myth that the criminal justice system is this like monolithic, homogenous beast, a prison is a prison is a prison. And that is not at all true. So this is just sort of the map of a mess of what some people might experience as they go from, and allegedly committing a crime to the period at which they're out of a system. And people can cycle through any of these decision points over and over again as they have charges filed, as they have those charges adjudicated, as they're sentenced, as they complete their sentence, all of those things. And how people experience moving through the system like this varies very much depending on where you live. And where you're incarcerated. So, the experience you just heard about in Texas is very different from people's experience with the criminal justice system in Connecticut, for example, where I practice. Another important myth is that most people who are involved in the criminal justice system are in prison or somehow charged with a new offense, like they did something and are incarcerated. So of the more than 5.5 million people who were under some form of correctional supervision at year-end 2020, the majority of them were on probation, and a significant other proportion, 15%, on parole. So these are people out in the community, right? They're not like walking around in orange jumpsuits. I mean, you're not going to know that they're on supervision, but these are our patients. These are our clinical trial participants. Hopefully these are our, the people that we interact with all the time. A much smaller proportion are actually in prison or jail. And if you kind of zone in on jail itself, so 1 in 3 people who are behind bars in the United States are in a jail. And most of them are not yet charged. So they've not yet been convicted of a crime. They've been charged, but not yet convicted. So, innocent till proven guilty, right? So The majority of people in jails who are being held for local authorities are not yet convicted. They're being charged with a variety of crimes, violent, property, drug-related offenses, or public order offenses, but again, not yet convicted. A much smaller proportion have been convicted already. And many of the people who are incarcerated in jail are there not because of a new offense, but because they were unable to post bail for an offense for which they were charged. And so these, until bail reform happens, and what's happening in terms of bail reform matters on where you live. But until that happens, this is essentially incarceration because of poverty. And it really just contributes to health disparities. There's this misperception that sort of only men are involved in the criminal justice system. However, the US incarcerates more women than any other country worldwide. And while we have 5% of the world's women, we have 30% of the world's incarcerated women. And the rate of rise of state prison population for women have grown much faster than men. So between 1978 and 2015, the number of women in prison grew by significantly more, something like 800%, as opposed to the proportion of men in prison, the population of men in prison that grew by only 300%. I mean, still 300% is awful, but there is this huge difference here. And I know you'll hear about this more in a moment, but prison systems were really designed by and for men, and that includes the consideration for women's health care. So incarcerated women are often an afterthought in terms of how systems operate. There are approximately 231,000 women and girls currently incarcerated in the US, and 2 million women are jailed annually. About half of all women in the US prisons are mothers, and about 80% of women in jails are mothers. And that means that their incarceration has really important implications, not only for their own health and their own, personal trajectory, but also the health of their children, the health of the community, the health of the family, right? There's like a very broad reaching impacts of incarceration for women. There's a misperception that incarceration is effective drug treatment. I put that in quotes. So I won't stand on my political soapbox for too long, but there is a misperception that getting tough on crime and having a war on drugs essentially translates to having a war on people who use drugs. So a lot has been blamed on poor old Nancy Reagan for her Just Say No campaign, but this sort of misperception has carried through to today. So just as an example, Jeff Sessions, sort of verbalized what a lot of people believe, that you have to be able to arrest people and then you're intervening in their destructive habits, Sessions said. Many people never ever recover from addiction except by the grave. I hope that that if nothing else that you take away from this talk is that this is inaccurate, that for people with substance use disorders, evidence-based treatment does not include incarceration. So because of this, because of these policies and because of these perceptions, people who are incarcerated in state prisons and jails have a much higher rate of diagnosable substance use disorders compared to the general population. And yet fewer than 15% of them receive appropriate treatment or evidence-based treatment for substance use disorders while they're incarcerated. So it's been estimated that only 23 out of 3,200 jails and 4 out of 50 state prison systems provided medications for opioid use disorder when the Marshall Project studied it in 2017. That number's grown, but there's still a big gap. So what happens? Someone's out in the community with their untreated or undertreated substance use disorder. They often are at higher risk of arrest and incarceration related to their substance use disorder. Sometimes, it's because of a drug-related offense like possession or trafficking. Sometimes it's because of the things that people do, while they're trying to obtain drugs or as a consequence of using drugs and while they're intoxicated. But so people who are incarcerated, and then in the absence of effective treatment during incarceration, they're essentially forced to have observed detox. They ride out their period of incarceration. Maybe they are able to acquire some illicit substances while they're in. That happens sometimes, but maybe they just ride it out. Then they return to their community and they still have untreated substance use disorder, right? So this cycle continues. Now, you can certainly take the approach, as I mentioned, Jeff Sessions did, that the only way out of this cycle is death. And we do know that there's a very high rate, 40-fold increased risk of death in the 2 weeks following incarceration, primarily due to overdose. I'd like to argue that there is another way out of this cycle, and that involves treating people's substance use disorders using evidence-based methods to treat their substance use disorders, which we know not only has better benefit for their health, but also reduces the risk of incarceration. Finally, with the full caveat that I am not a bioethicist, there is this myth or misperception that people in prison can't participate in research. And that includes potentially some of the clinical trials that you all are involved in. So we do want to consider prisoners as a special population for clinical research. And that was really laid out in the Belmont Report in 1979 that said we have to establish protections for research participants and potential safeguards for these special populations because of concerns for potential exploitation, coercion, constrained autonomy, and the risk about, being able to maintain privacy in a very not private facility. However, you have to balance that with the fact that clinical trials often means early access to things. We've seen that during COVID, right? Certainly it meant expedited access to vaccines, to experimental treatments. And so there's really a risk of excluding people who are involved in the criminal justice system because then they don't benefit to, get all the potential benefits from participating. Now, who's considered a prisoner is sort of a broad question that was laid out in an Institute of Medicine 2006 report. It does not include just people who are incarcerated in prison. It also includes people who are incarcerated in jails or other closed settings. And it sometimes includes, in certain situations, people who are under community supervision. So those are important things to consider because they're still sort of under the jurisdiction of the state. So consider that, and consider that certainly people's participation can be informed, deliberate, and voluntary, and people need the opportunity to participate and to help inform design, interpret findings, and disseminate findings. And there's this sort of dictum of nothing about us without us. So just, ensuring that inclusivity of people who are incarcerated in clinical research. So in summary, that was a whirlwind tour. Maybe some of you have whiplash, but I'm happy to answer questions as we go forward. I've tried to bust a few key myths here and just show you that the criminal justice system is heterogeneous and complex, and we want to use appropriate terminology to reduce stigma and shame about justice involvement. That most people's involvement with the criminal justice system is in the community. And whether or not you know it, these are your patients and your clients and your research participants. Women in particular in the justice system are often neglected and ignored. People involved in the criminal justice system very often have substance use disorders that are undermanaged while they are incarcerated. And that leads to high rates of future justice involvement and overdose deaths following return to communities. And people involved in the criminal justice system can also be involved in research. And that's it. And here's my email. I know we'll get to Q&A, but if you have questions, feel free to email me as well.
Well, thank you for that, Jamie. That was great. Definitely a whirlwind, but really important information. I don't see any questions in the chat, but I would encourage people to post questions there. While we're waiting for people to do that, I have a couple questions that I think might be relevant to this crowd. So I would start with what should someone do? So say they have participants who are in their research study and they find out that one of their participants has become incarcerated. So what should a researcher or what should the study team do if that happens?
Yeah, I mean, I think that it happens more often than we realize, right? So often, even in clinic, right? Someone no-shows us and we're like, oh, where are they? Oh, they're incarcerated. I think it really depends on what the protocol calls for. So there are certainly times in our research studies where we have stipulations where if someone's incarcerated for less than 6 months, their participation in our study will continue, and we actually go into the facilities and interview them there. And sometimes we wait until they return back home to communities. And just be aware that while people are incarcerated, they're often not able to receive incentives for their participation in research. So like for our studies, we wait until they return home and sort of give them an IOU until they get back home again. But there's certainly important need to keep people engaged, just realizing that for the majority of people, they're going to be incarcerated for shorter periods of time.
Maura, it looks like you have a question.
I do actually. I'm sorry if you already mentioned this, but I wanted to ask, in that graph where just like the lines for male and female, incarcerations over time just splits. Do we have an idea of like what is causing that? Like just maybe the top few reasons?
Why the rates of incarceration for women have increased at such a faster pace compared
Yes.
to men.
Mm-hmm.
I mean, a lot of it has to do with drug laws. I don't know, Mishka, if you're going to speak to some of that as well. But yeah, a lot of that has to do with sort of prosecution and conviction for drug related crimes.
Thank you.
And I think we have time probably for one or two more questions. Another question I had is thinking about, so we had this hypothetical situation, which I think occurs fairly frequently, that a study participant becomes incarcerated or a patient becomes incarcerated. What are things to think about when someone is coming out of that setting, and what are some unique challenges? So I think you spoke about the high mortality and risk of overdose, and maybe you could expound upon that, but also some of the other challenges that people face when they're coming out of incarceration, returning to the community.
Yes, so many. And, so it's often that discharge from facilities is not well planned, especially depending on where you live. And so people are sort of like dropped off from from a van in like the middle of the night, or dropped off after a court date with sort of little preparation. So yes, first, as we're talking about substance use disorders, consideration for the fact that they probably didn't have them treated while they were incarcerated. Very high risk of overdose. So you want to make sure people have access to naloxone and you get them started on treatment for their substance use disorders. But if you talk to our patients, the numbers 1, 2, and 3, and 4 things that they're worried about are housing. So very often people after return home don't have a stable place to go back to. And so that becomes really important. I would say another is insurance. So Medicaid and Medicare are supposed to be frozen while people are incarcerated, but often people are disenrolled and they might need identification to get re-enrolled. Those things you might not have access to your license and birth certificate when you're returning home from prison. So those things can be really challenging. And then certainly like reuniting with the family and with your healthcare providers can be really challenging as well. So just making sure that there's like a lot of wraparound support to connect people to care.
Yes, I would agree with all of those. And I think the challenges are just enormous. And often the priority is not let me get back to my research study visit, or let me get back to my doctor, because they have so many other things and responsibilities, other people to take care of, and themselves, and housing, and all of the rest. So I would echo that. This group seems to be a little bit shy. I don't see any questions in the chat, so don't be shy. But I'll ask one more, and then I think we'll go to the next speaker. But so the last question I wanted to ask was trying to end on maybe a little more optimistic note, and thinking about what have you seen to be successful programs. I think specifically I'd be interested in hearing about substance use disorder, and maybe identifying substance use disorder when people are incarcerated and getting them started on treatment. And what do you see maybe that is working, or some successful models for that?
Yeah, so, I think we have evidence-based methods for treating substance use disorders. People just need to have access to them. So yes, certainly some of my colleagues have, like Sandy Springer, have done studies showing that if we can give naltrexone while people are incarcerated, one dose, prior to discharge, that they're more likely to have, engagement in care and follow-up doses of naltrexone after release. So that's one model, is sort of considering this sort of transitional period, and the other is, like a rapid startup, particularly of buprenorphine. Those are things that work to get people engaged. Certainly, there's a lot of models out there. I'll just throw those couple out.
No, that's great. Thank you so much. And I think there's really this is a growing body of literature, and we're really starting to see some very compelling evidence that this saves lives and reduces some of those overdoses like that we talked about, and also just can really improve outcomes for people, health outcomes, but also just make that transition a lot smoother back into the community. I do see one question that's posted in the chat, so we'll do that one real quick, and then we'll move on to the next speaker. So the question in the chat is, have you seen reports of under-treatment of withdrawal in prisons when MOUD is available?
For sure. I mean, from our patients, absolutely. I mean, and it's not always in prisons. It's more often in jails, because that's really where people are often going first. By the time they get to prisons, they're often stabilized. But yeah, withdrawing if you can just imagine, like the place where I used to work, the facility where I used to work, there was a single room with 3 sets of bunk beds, so housing 6 women at a time, all withdrawing, and maybe you get some Imodium thrown at you, and maybe some Advil, but I mean, that's about it. It's absolutely can be a miserable experience, even when MOUD is available. In some of the places where methadone, for example, is available, it might be restricted to pregnant women or to people who were stably on a dose prior to incarceration. So even when it is available, it can be difficult for people to access. What we want is for facilities to be able to offer it to everyone who needs it, and to initiate while they're in.
Great. Thank you so much, Dr. Meyer. And thank you for the audience for posting a question. We're going to move on to our next speaker. And I think this will be a seamless transition, because I think we're going to touch on some of these questions that have come up and issues that have come up. So our next speaker is Dr. Mishka Turplin. Dr. Turplin is board certified in both obstetrics and gynecology and in addiction medicine. His primary clinical research, public health, and advocacy interests lie along the intersections of reproductive and behavioral health. He's the medical director at Friends Research Institute and adjunct faculty at University of California, San Francisco, where he is a substance use warm line clinician for the National Clinician Consultation Center. Dr. Turplin has active grant funding and has published extensively on health inequities, discrimination, and access to treatment. He has spoken at local high schools and before the U.S. Congress, has participated in federal and international expert panels, primarily on issues related to gender, reproduction, and addiction. So
great. Well, thank you. Thank you so much for inviting me, and I really look forward to the conversation. I was going to, and I want to note that both Dr. Meyer and I are using the terminology of the criminal legal system, not justice, because it's a real question of how much justice the system actually provides. And I wanted to sort of cast a broader lens, at least initially, and really talk about the intersections between sort of reproductive health and, and substance use disorder life course, and how and all the places in which that is criminalized, both on the individual level, as you can see here from this collection of news stories in which, different judges are, ordering both men and more often women to be sterilized in order to, be released from prison, have reunification with their children, and et cetera. And on the right-hand side, a really kind of famous community-based program, I put that in quotes, which was paying people, who use drugs to become, sterilized or to have long-acting reversible contraception. So these illustrate sort of issues of coercion, both around substance, but in particular around reproductive health decision-making. And Dr. Meyer touched on this, sort of the history of US drug policy, in a way is how a health problem, substance use and use disorder, becomes a crime. And I would like to add to that, I hope through this today, to illustrate how our practices as both physicians and researchers can become complicit with structures of policing. And so there's really a parallelism between the initiation of the modern era war on drugs that Nixon launched in 1971 and, the prosecution of people who are pregnant for drug use. The first known indictment was in 1977, and almost every single state has arrested, tried, convicted, somebody for using drugs in pregnancy. And there's a parallelism not just between these more extreme sort of criminal legal events, but also as we I think about what we call the child welfare system, which is both sort of foster system and what's also in many states called child protection. There's a parallelism between that and the war on drugs as well, which is illustrated very well in this white paper from the Movement for Family Power detailed below. But on the top left, this is sort of looking at the rate of change in funding for both, the criminal legal system and, for the child welfare system. A 400% increase over 2 decades for the criminal legal system, and a 20,000% increase for child welfare. And on the right, this is contrasting sort of the number of people incarcerated on the bottom with the number of people placed into the foster care system. And whereas in the last couple of decades, there's been a gradual and insufficient, decarceration in the United States, the past 2 decades have only seen an increased number of people being separated from families and placed into the foster system. A system that people have described as really being, a foster, kind of to prison pipeline across people's life course. And this sort of increasing criminalization of pregnancy was reviewed in 2017 by Amnesty International. Really in many ways motivated by a particular statute in Tennessee that criminalized substance use in pregnancy. Most of the other statutes are civil, not criminal, but really noted a marked increase over the prior decades in terms of people who are, prosecuted, convicted, and imprisoned for issues related to pregnancy. So I know you wanted me to talk about, pregnant people, behind bars, but I really think there's 3 different, dimensions. I will. But one is like, there's this, there's movement to kind of keep people who are incarcerated and capable of pregnancy from getting pregnant. Second is sort of the provision of care for people with, let's say, opioid use disorder in jails and prisons. And the third, which is what I've already touched on, this concept of pregnancy criminalization and these sorts of increasingly restrictive reproductive health policies that nearly further the criminalization of people capable of pregnancy. So for the first one, to really kind of talk about like how, programs that have tried to keep people from who are, capable of pregnancy from becoming pregnant during, the period of incarceration. And this was published in 2019. This was a collaboration between local jails and public health agencies to offer, reproductive health education and long-acting reversible contraception only to people with opioid use disorder in Tennessee. And you can see, this is the quote from, the motivation for this. Unfortunately, jails in Appalachian, Tennessee, precisely the countries where incarceration of women is growing exponentially, have neither the necessary resources nor a legal mandate to provide preventative reproductive health care. And this is a complex statement that, bears sitting with. The idea of a legal mandate, the idea of sort of uncritical acknowledgement of the growth exponentially, and really sort of the sadness that, I'll talk a little bit about Carolyn Suffren's work coming up, but the idea that sometimes jails are the only place that people can get needed medical care. And that's certainly reflected in the fact that the only people in the United States with a constitutional right to health care are prisoners. So the main focus of this project was really a cost savings one. They thought, by providing long-acting, by contracepting people with opioid use disorder during their period of incarceration, they could prevent future pregnancies, thereby prevent NAS, which somehow I misspelled there, and thereby save money. And this was their sort of conclusions of how this project worked. There's a lot of problems with this paradigm, and we called it out in this letter to the editor. One, it's unethical to only provide long-acting reversible contraception. There should be a menu of options. People should be allowed to choose. What is choice in an incarcerated context? And finally, like how they calculated, the numbers of pregnancy and pregnancy prevention assumed that every pregnancy would be carried to term and deliver a live birth, which is clearly not epidemiologically grounded. So the second thing to talk about is the provision of medications for opioid use disorder for pregnant people who are incarcerated. And you all know this. I don't need to remind you of this, but this is, the standards of care. Methadone and buprenorphine are the safest. We don't recommend transitioning from one or the other, and that medically supervised withdrawal, or colloquially known as detoxification, is not recommended. So this is also Carolyn Suffren's work. That is a survey of jails in the United States. And the reason for jails, and I really appreciate the distinction between jails and prisons and et cetera that Dr. Meyer laid out, is in many ways jails are more proximate to the community. People have to pass through jail to go to prison. So kind of looking at what the provision of services are for pregnant people who are in jail is helpful to know. And this was a survey to all of the jails in the United States. There were about 800, about 30% actually responded. Of these jails, a few, only 30%, conducted routine pregnancy testing at intake or within 2 weeks of arrival. Overall, 60% of the jails said they provided any medications for opioid use disorder. And half of them said they did both initiation and continuation. But a third of the jails provided withdrawal management only, something that is clearly, not within the standard of care. So it's been said, and I'll show you this in a quote coming up, that really the proximity of clinical care to policing is nowhere closer than during the birthing hospitalization. And most child welfare reports, for infants in the first year of life, come from health professionals primarily because of drug exposure. And although there's been no change in the increase in reporting across any workforce, police, schooling, families, or anonymous in the last 2 decades, there's been an over 400% increase in reports from medical professionals. And that's probably driven by sort of the misuse or overuse of urine drug testing. And this has been compounding, existing racial inequities. As illustrated here on the right, these are data from a national, child welfare data, unpublished still, and this is the sort of screened in reports from medical professionals for drug exposure over time. And you can see, whereas there's been an increase over time, there's been a phenomenally greater increase initially for American Indian kids and more recently for Black children. So I will say that I don't think this is, that drug testing in and of itself during the birthing hospitalization is not a clinical test. It's a pregnancy test. It's been called out by professional societies here on the left-hand side from the American Society of Addiction Medicine, equating this with abuse or neglect is inaccurate, inappropriate, leads to punitive approach, which harms the patient's trust, and et cetera. And on the right-hand side is the ACOG statement that really says that laws and policies, that criminalize behaviors and criminalize parts of pregnancy require healthcare providers to function, as agents of law enforcement. And this sort of illustrates, I think, this where, people have talked about, the crack baby as this symbol of where, the war on drugs, i.e. US drug policy, collided with the war on abortion, i.e. reproductive health policies. And I think we are living, both in the after effects and the continuation of that sort of collision. And I think for many of us who work in this space, we're quite concerned with how, the Dobbs decision is going to affect state policy and consequentially actually affect, the care and the further criminalization of pregnant and parenting people who use drugs. So in conclusion, I think we really have to be attentive, to how structural sexism intersects with this racialized drug policy across an increasingly heterogeneous and in some places punitive state policies, and all of this taking place in a landscape of really chaotic and hyper-local child welfare policies. And I'll illustrate this briefly just with a story. And I used to have a clinic that was in a jail close to Richmond, Virginia. And it was a county that had a drug court. So if and a drug court was like a diversion program from incarceration. And the medication used was naltrexone, which is not recommended in pregnancy. So if you were pregnant and ended up in the drug court, you went to jail. If you weren't pregnant, you were, could remain in the community under supervision. Once you got to jail, the jail only provided medications for people who were pregnant. So then there's an advantage by gender and reproductive status or type, to receipt of medications in jail. But if you remained in jail, and delivered and then returned to jail, you were no longer pregnant and you no longer received medication. And so people underwent, just to answer the question, that was posed in the thing, an involuntary detox. So there's a lot of ways, I hope I've illustrated how, these sort of different realms of drug policy, reproductive health policy, and a landscape of criminalization that is beyond just what's behind the bars.
Great. Thank you for that really provocative talk. I thought that was fascinating. Again, while we're waiting for the audience to become brave and post some questions, I have some questions for you. So I think first, the issue of sort of reproductive health or contraception for women who are incarcerated and choice around that. In your experience, do most facilities even offer contraception for women either in jail or prison? And I see you shaking your head no.
Yeah, So I think just to add, and Dr. Meyer, jump in, so there's like the federal prison, which is actually has the most, has a board of medicine, like sort of healthcare guidance board, has documents on detailing best practices. There's state prisons, which provide probably a lesser, but okay quality of care. And then there are jails, and jails are really under the jurisdiction of the local sheriff. That whole budget is local. And so they're making, healthcare decisions based upon, fixed, finances and things like this, because your Medicaid stops. There's no insurance coverage for people in jails. And that's a whole, and there's work to try and kind of change that, even at the federal level. So the short answer is not really, except in specific programs and places that have, sought to do this. And the example in Tennessee was using, public health data to fund a contraceptive program. Not in and of itself a bad thing, but the length, how it was oriented, was problematic, and the restrictive, options available, sort of compounded that.
Yeah, interesting. And then I think, it really also speaks to pregnant women as being treated as sort of this special population, or a different population, and sort of the variety of what's available in terms of medications for opioid use disorder. And you kind of highlighted that paper. Is maybe just more specific, maybe to that paper, or just your experience, is that the norm in most facilities where there are policies that are directed towards pregnant women and will have resources for MOUD for pregnant women, but not for women who are not pregnant, or for men, or for other people in those facilities?
Yeah, I think as time goes on, more places are providing medication, but and it depends. There's, like for every jail has its own relationship. Some, the ones that are more likely to provide medication for opioid use disorder are actually ones that, or initiation, would be ones that actually provide buprenorphine. Continuation, it's ones that provide only methadone, and they have, like either their own OTP, that's pretty rare, but like, some relationship with a local provider. And in places in urban areas, more likely to provide MOUD for pregnant, folks than places that are rural. Places in the Northeast more likely. So there's a lot of sort of, like regional differences that map onto some degree of common sense. But I think generally speaking, this is a place where there's like, a bias that privileges pregnancy, not necessarily reproductive health or postpartum, or anything like that, once you're behind the bars. But the sort of diversion sort of punishes, so to speak, literally, like, pregnancy.
Yeah. And are you aware of people becoming incarcerated because they were pregnant and using drugs, that was a reason to incarcerate people, pick people up?
Oh yeah. And I think what we're seeing now, this is, actually it's not, this is not a red state, blue state thing. It's both in California and Oklahoma are the two states I've been most involved with court cases. But it's not, there's a plus to your question, or to the answer. And it's, drug use and something. It's a pregnancy and miscarriage, or stillbirth, really being like the drivers. And these are criminal cases. These aren't, civil cases. These are people being charged, with murder for having a pregnancy loss, and, toxicology or autopsy showing, drug metabolites.
One thing I would highlight, and I'm not sure how familiar the audience is with the JCoin Initiative, which is really a network of researchers who are doing various projects around the country, looking at this transition specifically from people who are incarcerated to the community, and really trying to optimize opioid medications for opioid use disorder, and looking in various different settings, different populations, and different outcomes, but seeing how can we optimize that, and how can we improve that process, a lot of which involves engaging the community. When people are incarcerated, it feels like they are sort of shut away and cut off from all these resources. And people don't know what happens in there. It's like some black box, and then they come out and somehow are supposed to be able to access all these different services. And I think really improving, breaking down some of those barriers, improving connections and communication between people who are providing services in the community and those transitions of care. I think we're going to be seeing a lot more just innovative models and outcomes of those projects through the JCoin network. I do see a question in the chat, and this looks like it's directed to either speaker. So it says, can either speaker talk about if/how often prison or jail clinicians are engaged with Child Protective Services to develop plans of safe care when pregnant or postpartum patients are soon to be released?
But I just wanted the JCoin, it's great network, all of that. I'm not familiar with all of their trials. Some of the ones I am, pregnant people are excluded. And it might be across the board, which is common and unfortunate in research and hurts like the health of pregnant people and et cetera. Do you want to answer the question, Jamie, or
You start.
Okay, just so people, so plans of safe care is part of CAPTA, the Child Abuse Prevention Treatment Act. Hopefully it's going to be reauthorized in maybe this session or next session, and the language is going to change from a plan of safe care to a family care plan. So removing this sort of misnomer to some extent around safety and children and drugs. And it's for people who are, people who use drugs, people with use disorder, that needs to be developed. There's a lot of heterogeneity in who does it and what it looks like. I guess all I'll say is I am actually unaware of it being having ever been done by staff in jails or prisons. Primarily, it's around it being done during the birthing hospitalization. Ideally, it's done during prenatal care.
Jamie, did you have anything to add?
The only thing I was going to add was that there are some facility, again, there's a lot of heterogeneity there, but there are some facilities, including federal facilities, where the infant is kept with the mother in a prison-based nursery following delivery. And so maybe that impacts some of the transition of care questions. Those are few and far between.
Yeah, and you had mentioned this earlier, Dr. Meyer, and I just want to amplify it, the fact that many people, in fact, most women incarcerated are parents, and many of the men who are incarcerated are parents. And we think about ACEs, right? Adverse childhood experiences. One of the ACEs is having a family member who's incarcerated, right? And the association between ACEs and subsequent substance use in a punitive drug policy environment that becomes criminalized. You can see how that's another sort of self-fulfilling sort of cycle.